Hello, and welcome to an educational session talking about continuous veno-venous hemofiltration, CVVH-f. If you look at the address below on the screen, you can see a video and an address of a YouTube of a video talking about continuous arteriovenous hemofiltration, which is the basics on how to utilize a very simple renal replacement method that now has been forgotten, but that method continued to be applicable and essential for areas where you don't have infrastructure. Now, the secret is to utilize the mechanism of convection and ultrafiltration as a form of renal replacement therapy rather than dialysis. When you talk about dialysis, there is a semi-permeable membrane that you place across that semi-permeable membrane a form of fluid which is called a dialysate, and you exchange the blood with these factors that are present in the dialysate, like bicarbonate, and you remove the factors that you don't want from the blood, like potassium. But in this form of renal replacement therapy, you actually, all what you do is pull the plasma water that contains the unwanted uremic poisons and the unwanted impurities and replace that with, called replacement fluid, with a fluid of your choice that can be designed to meet what your needs are. Could be peritoneal dialysis fluid, could be lactated ringers in extreme situations, or could be D5W with bicarbonate infusion. So in this form of renal replacement therapy, and if you notice I'm using the term renal replacement therapy and I'm not using dialysis, the reason is that we are replacing the kidney function with a modality, but not through dialysis where we exchange, but through ultrafiltration and convection where we pull the bad stuff and replace with clean stuff. Now, the difference in these two modalities is when you talk about dialysate and conventional hemodialysis, you're talking about the need for serious infrastructure. This is a dialysis machine that requires a lot of testing and requires a lot of technical knowledge. You're going to have either a nurse or a technician who knows how to operate the machine and knows how to set it up. Setting up the machine is not easy as well. You have to have dialysate, you have to have different fluids, and you have to have reverse osmosis for appropriate water treatment to be used in dialysis. So in a way, you have to have serious infrastructure, and it takes time to set things up of that nature. Renal replacement therapy using convection and using the filtration while you remove fluids and replace with clean fluids does not need any of that infrastructure. All what is needed is basic tubing. That it is this tubing, and if you look at the bottom of the screen right here, the address on the web for the name of that tubing is going to be listed, and this is the tubing, and it's just basic simple tubing that has two ends, that has a filter end and a patient end. This goes into the catheter and this goes into the filter. You need two of those tubings. It has also a pump segment. You also need a double lumen conventional dialysis catheter that is placed in one of the veins. Could be placed in the right femoral vein, left femoral vein, or even in the internal jugulars up top. You need a blood pump. This blood pump is actually a blood pump out of a functional Fresenius dialysis machine pump, and this is a disclaimer that Fresenius has not approved this, nor the makers of these tubings have approved this, nor the FDA. This is an explanation of a modality that is used only in extreme situations. So this blood pump is actually a functional pump that came out of a Fresenius machine, and if you look at the address down here, you can see a link to a YouTube video that I have set up on how to take this pump out of a machine and convert it into a functional pump. This pump would work on a 9-volt battery. This pump would work on a car battery. This pump would work on a solar panel that delivers 9-volt battery. It would work on cell phone chargers. So really, in a way, this is a relatively functional pump. And then you need a simple filter that you utilize for ultrafiltration, where you keep one end capped and tight, and filtration is going to come out of the other end. And then you connect the other side of the filter back to the patient using the same amount of type of tubings. Now keep in mind, the filter has to be after the pump. Here's the pump. The filter has to connect after the pump. The reason is that you have to create a positive hydrostatic pressure within the filaments and the hollow fibers of the filter, because if you place the pump beyond the filter, it is suction and it creates negative pressure, and ultrafiltration would be very limited. Now, again, I take you back to CVVH-f. CVVH-f does not utilize a pump, but use an arterial access and a systolic blood pressure as a pump. Now, this modality can be used in even more extreme situations, but the problem with this modality is the fact that you are totally dependent on an arterial access and the systolic blood pressure. There is some technical problems with an arterial access where you may not have the right catheter, or patients who are hypotensive and septic, and if they are on pressors, you have intense arterial vasoconstriction, so the flow within the arterial catheter may be limited. And if that limits the blood flow to the arterial catheter, it limits the perfusion pressure to the filter and the ultrafiltration as well. So you're under the mercy of the systolic blood pressure. You're also under the mercy of the resistance within the circuit. Keep in mind that any filter that you have will give you a difference or a drop in the blood pressure from one end to another. If this is the arterial side, right here, and if this is the venous side, as blood goes from the arterial side to the venous side, there is about a 40 millimeters of mercury, a step down drop in the blood pressure. So if the blood pressure is 80 on this side, it's going to come out on this side in about 40. Now, if you have a patient on a ventilator who is on a 10F PEEP and the patient is volume overloaded with a CVP of 15, so the resistance, the venous pressure right here, is about 25. So you add 25 to 40, which is the step down in the systolic blood pressure. So you're down now to your resistance is about 65 millimeters of mercury in a drop in the blood pressure. So the perfusion pressure is only 15 millimeters of mercury. Knowing this and knowing how long that tube is, and the arterial catheter may have a lot of resistance, so this is a very, very unreliable method of utilizing the systolic blood pressure as a form of renal replacement therapy. And this what drove the next stage of renal replacement therapy modality and thoughts into a veno-venous, utilizing a dependable blood pump, and this is a blood pump that we used for that modality. The other risk of CAVH is actually related to the presence of the catheter, and if the catheter stays in the artery for a long period of time, there's a risk of clotting, there's a risk of limb ischemia, there's a risk of injury to the artery, and we're talking about arterial injuries may have to have surgical repair, and that opens a new layer of potential complications for the sick patients. So, CAVH is a modality, not very dependable, lot of risk. CVVH-f, a lot more dependable, much less risk, and you have the pump to utilize as a form of propelling the blood from the venous system through the filter back into the venous system. Again, the pump has to be pre-filter, because when it's pre-filter right here, it pushes the blood, and the pressure within the fibers is going to be a positive hydrostatic pressure, and that allows the convection and allows the filtration to leak out from one end of the filters. If it's placed here, then there is suction, and the pressures within the fiber is going to be negative, and you would not be able to have filtration. Now, after we talked about the basics and the principles, I wanted to re-emphasize the idea that you would need only one catheter, which is a double lumen conventional dialysis catheters in one of the venous system or the large veins. This could be the right femoral vein, the left femoral vein, right internal jugular, and possibly subclavian. But the most convenient place is the right femoral vein at this time, unless there's contraindication like an injury and so forth. So, the catheter is here where it has double lumens. One is the arterial limb, even though it's called the arterial limb, but it's an intravenous catheter. The arterial limb, or it's colored red, that is where we can pull the fluid out based on the dynamics of the catheter. And the venous return is still also an intravenous catheter, but that's where the vein returns. So, when we talk about the connection, we're going to connect our tubing into the arterial limb to the pump, and then to the filter, and then back from the filter to the venous system, back to the patient. So, this has already been connected and primed in order to show you that now the venous return is very easy. What I'm going to do is I'm going to demonstrate how to connect the arterial side and how to connect into the pump. Mind you, this is a pump. Again, the way you get this pump, if you look at this YouTube right here, the address shows you how to take this pump out of a conventional dialysis machine and convert it into a simple pump. This pump would work again on a 9-volt battery, 12-volt battery, car battery, cell phone charger, and any kind of converters. And it has positive and negative. Now, if you are doing this, keep in mind the pump has to be rotating clockwise. If it's rotating counterclockwise, or what you have to do from a technical electrical standpoint of view is reverse the connections. Now, the tubing has a what we call a pump segment, which is the segment that's going to be sitting inside the pump. Now, the proximal element of that tubing has to be the patient end. This is the patient end that connects here. So, the way you connect this, there is a lever right here that you push it down, and then the tube is in, and then you can hand spin your pump and push the tubing in, and you continue to push it. And you can see the tubing is all the way in. Now this segment, which is and then you close the door. Now this segment, or the intake, is connected to the patient as such. And this end is connected to the filter. As such. So now this segment is connected to the filter, and this segment is connected to the patient. So now we have a closed circuit. This is a tubing that is connected to the arterial outlet of the double lumen dialysis catheter. Blood goes out within the tubing into the pump. And if you look at the pump will turn clockwise. So the blood continues to be vacuumed out through the tubing into this large tube that goes into the filter. The proximal end of the filter is actually sealed. Think about it that these fibers would have a positive hydrostatic pressure. So if you open the second portion of the dialysate side of the hemofilter, fluid is going to come out, and that is what ultrafiltration is, and it will pull with it a lot of the waste products. Now you would have about almost 500 to 700 cc's per hour of fluid come out of here. Now this is what we call dirty fluids, or effectively urine. And then in the venous segment, where it comes, the blood continued to go here and returns back all the way back to the venous limb of the dialysis catheter back to the patients. We have a port, and in that port we can infuse what we call replacement fluids. Again, this could be bicarbonate rich fluids like a D5W with 3 amps of bicarb. This could be in extreme situations lactated ringers, as long as the potassium is not high, since lactated ringers contain some potassium and you have to have a healthy liver that converts lactates into bicarbonate. Or you can actually infuse dianyl, which is peritoneal dialysis fluid, right in that port, as be considered as a replacement fluid. Now think, if you're having 700 coming out of here and you're putting 500 in here, you may be effectively having 200 cc's of urine output per hour. If the patient is dehydrated, 500 coming out of here, you replace here with 700. If the patient is massively volume overloaded, 700 come out of here, you replace with 300. So in a way, you have the ability to control the negative fluid balance by adjusting the replacement fluid rate and in comparing that to the rate of ultrafiltration that's coming out of the filter. Now, this is something very interesting. This is a cell phone charger that is plugged to an electrical outlet. And this is the two ends of the cell phone charger that I'm going to connect to the pump. And the purpose of this connection is to show that with 9 volt or 12 volt, this pump will be functional. Now, if you look at this pump, it is now working with our connection, which is a 9 volt cell phone charger, and it's working in a clockwise fashion. So now we have a closed circuit with a working pump. This is a double lumen conventional dialysis catheter that is intravenous catheter. Both ports are intravenous. The red limb is called the arterial limb, and it's a metaphoric arterial limb related to, this is where you pull the blood off, which is called the arterial limb. Blood is pulled out into the blood pump, and if you notice, it comes out here, and this pump is specifically designed with a tubing, and the name of the tubing is right here on in front of you on the screen. And then blood comes out to the filter. Keep one end of the filter locked and sealed, and this end, if it's open, since there is positive hydrostatic pressure within the fibers of that filter, ultrafiltrate or fluid will come out, and in a way that is considered urine, and then actually the blood continued to flow through the filter to the tubing and back to the patient. So this is a very simplified schematic diagram of how you can create a extracorporeal blood circuit powered by a pump. That pump is actually powered by a cell phone charger or a 9 volt battery. By the way, 9 volt batteries can even provide power for 2 hours. So if you have a patient that needs an emergent treatment where we do renal replacement therapy, not dialysis, renal replacement therapy utilizing filtration and convection and replacement of needed electrolytes and minerals with replacement fluid, but we remove with convection and filtration, then this is a simplified way of doing that. Again, this can be functioned with a 9 volt battery, so if you have that patient, you can, if you want to run him for 8 hours, you can use 4 batteries. Each one will last for 2 hours. You can use a car battery that can last for days. You can, if you have an electrical outlet, you can use a 9-volt or 12-volt cell phone charger. Pump speed is preferred to be at 200. The reason I want it to be at 200 is if you create a lot of negative suction and negative pressure, there is a chance of aspirating air. So I prefer to place a bio-occlusive dressing over the venous stick where the catheter is in, and make sure all the connections are really, 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 really tight. So a bio-occlusive dressing, very tight connections, pump speed no more than 200 cc's a minute, which is equivalent to 17 revolution per minute, tight connections, open distal segment of the side port of the hemofilter, eventually connected to a tubing of a Foley catheter. Then you can collect the filtration, which is effectively the urine, in a bag and measure that on an hourly basis. And there is a port in the venous return segment of the tubing that you can connect the replacement fluid in that port. So now you have, in a way, a basic, effective, primitive form of renal replacement therapy in dire situations. You do not have to have the infrastructure that is related to reverse osmosis water treatment. You don't have to have dialysate jugs and bags, and you don't have to mix powder with water. You don't have actually to have a dialysis machine. You do not have actually to have technicians who know how to run a dialysis machine and troubleshoot when the machine is not working well or the machine is alarming. All what you have to do is have a blood pump, venous access, and the proper tubing. Now, if you have a patient that has tremendous amount of volume overload, pulmonary edema, that you need to remove a lot of fluids, then you will continue to allow 500 to 700 cc's of ultrafiltration to come out of the, what we call the urine port or the filtration port of the hemofilter. You will always, again, I want to emphasize, always need to have some element of replacement fluid. The reason is that when you remove all that fluid, you're removing a lot of calcium, which is essential. You're removing a lot of potassium, which is essential, and you're removing a lot of magnesium. So all these three elements are also removed. So based on the levels, you will determine how much to replace. So if the calcium is low, then you check the calcium every 6 to 8 hours and give calcium as much as needed to maintain adequate calcium level. If the magnesium is low and if the potassium is low, you replace accordingly. But you always have to have replacement fluid that will contain these elements. Now here's a trick that I will share with you about if you want to increase the ultrafiltration. If you really want to increase the ultrafiltration, you have to increase the hydrostatic pressure within these fibers. And the way to do that, either you can increase the pump speed, and then we have this gadget that you can crank it up. You notice the pump speed has increased. Or you just get a hemostat and bend this catheter a little bit, and once you increase the resistance in that catheter within the hollow fibers of the hemofilter, increase, and that increase ultrafiltration. So you may go up to 1200 or even 1500 cc's an hour. In that situation, you would immediately relieve pulmonary edema. Keep in mind that it's all about pulmonary edema. It's not about the total body edema initially. If patient is having hypoxia, hard to oxygenate, become intubated on the ventilator, the most important thing is to clear their pulmonary edema. And they may not take more than 5 liters of negative fluid pressure. The rest of the body may take a little bit longer to ultrafiltrate and remove that fluid, But for the pulmonary edema, the maximum you need to clear the fluid out of the lungs is probably a negative fluid balance of 5 liters. So really within few hours using this method, increasing ultrafiltration by either increasing the pump speed that would eventually effectively increase the hydrostatic pressures within the fibers, or bend or put a small hemostat to create just a small amount of narrowing into the venous limb of the circuit, that would also increase the hydrostatic pressure within the fibers of the hemofilter and will increase ultrafiltration. So we can do this by increasing ultrafiltration, but keep in mind again, you will always need replacement fluid that will contain calcium, potassium, and magnesium. And if you're replacing with dianyl or you're replacing with bicarbonate, you have to also monitor the fluid and acid-base balance. So it is always essential to replace these 3 major minerals. Ultrafiltration can be variable, and hydrostatic pressure is what drives ultrafiltration. Now with this, hopefully anybody can watch this video and understand the basics of renal replacement therapy, not dialysis. Again, renal replacement therapy utilizing the concept of convection and the concept of ultrafiltration and cleaning the body by convection, replacement with clean fluids, removing the impurities with convection, and removing the extra fluid out of the body utilizing filtration by creating a positive hydrostatic pressure within the fibers of the hemofilter. Blood comes out, goes to the pump, then through the filter, out of the filter back to the body through a double lumen intravenous conventional hemodialysis catheter. One end is sealed of the side ports in the hemofilter, and ultrafiltration is going to come out of this end, and this is in a way effective urination. Keep in mind you always have to have replacement fluid that will contain the elements that are needed as well. You may remove the impurities like creatinine, urea, extra potassium, but when your convection and ultrafiltration is large and is very effective, you will remove a lot of potassium that patients can become hypokalemic, so you have to replace potassium. You always will remove a lot of calcium, and patients with acute renal failure are already hypocalcemic, so your patient is at risk of hypocalcemia, so you will always replace calcium. Your protocol will depend whether you check it every 6 hours or every 8 hours, and you replace with intravenous calcium through venous return beyond the filter or through a separate port in the central system. Magnesium is also elevated in kidney failure, especially acute kidney failure, so you remove magnesium, but then the removal of magnesium is relatively effective, and then eventually you may have to replace magnesium. The most important thing also is bicarbonate replacement is essential because patients with acute renal failure would have profound acidosis and acidemia. So replacement with bicarbonate is also essential. In very, very extreme and dire situations, you may replace with lactated ringers, as long as the liver is healthy, that can take that lactate and convert it into bicarbonate, and there is no lactic acidosis and profound hypotension. Now, this is very interesting if you want to think way outside the box. If you're in a remote hospital where there is no conventional dialysis, there is no dialysis machine, no infrastructure, no RO system, no dialysate fixing and mixing and shake and bake, then you have a patient walks into your ER that gets intubated that has profound hyperkalemia, life-threatening, or severe pulmonary edema that they are so hypoxic needed to be ventilated. Now, in those extreme situations, if they are a chronic kidney disease patients that are on dialysis, where they have a fistula or a dialysis access, we can use this modality to actually pull fluid off very easily. Or we can use this modality to correct life-threatening hyperkalemia as well by allowing a lot of ultrafiltration and replacement of the fluid with bicarbonate-based fluid that is very low in potassium. So in a way, you are having the ability to utilize this primitive modality for dialysis patients who are traditional ESRD patients, but at the same time, if there is no dialysis equipment and if you're in a remote area. With this, I hope that I shed some light on simplification of a old, basic, and I would call primitive, but relatively effective and life savings. Keep in mind that not everywhere on the face of this earth have the luxury of having dialysis machines and RO systems and dialysate fixing and mixing. There are places barely there is water to drink, or there are places where there's barely electricity, but there is kidney failure and they need some form of renal replacement therapy. This replacement therapy can be utilized in the front line of war-stricken areas, earthquakes, massive humanitarian crisis, floods, and so forth, or remote areas for all practical purposes. I wish that hopefully this modality may help a patient on the face of this earth.